Well, good morning, everybody, and thank you very much for joining this NR Times event. And today we're focusing on the future of brain injury care. We've got a fabulous panel who will all introduce themselves in just a couple of seconds. But firstly, I'd just like to thank our sponsor for the event today, True Rehab, who aren't here in person, but I know many of you will know about the work that True Rehab have been doing, establishing a pathway for ABI rehabilitation with 6 residential rehab units, and they're doing some pioneering work. So if you don't know much about True Rehab, have a look online and please find out a little bit more about them. Over the course of an hour today, we're going to cover a lot of ground. So if anybody that's watching has questions or comments, we'll make sure that they find their way to the panellists who are speaking today. And I'd now like those panellists to just say a few words by way of introduction and tell you a little bit about who they are, the organisations they represent, and the work that they're doing. So if I could maybe start with Niccola.
Yeah, sure. So I'm a case manager. I'm the managing director actually at Keystone Case Management, and it's a little bit of a double act today with Jackie, because Jackie and I are in the same group now. So we're down in London in the southeast, and Jackie up in the northwest. So just coming from the perspective of case management, and I guess I always say our clients in a way are the lucky ones. They're completely unlucky for what has happened to them, but a lot of them are lucky they have this route to compensation, so we are able to procure support for them that's appropriate to them. So that's just the angle that I come from, that the case management model can be a very good comprehensive model to work with clients that have brain injuries.
Great. And as you mentioned, Jackie, Niccola, we'll come to Jackie next.
Hi, I'm Jackie Dean. As Niccola said, I'm also a case manager based up in the northwest. I have a case management company called Enable Services. We've been in existence for well over 20 years now, and I've been case managing for longer than that. My background is as an occupational therapist, and I've specialised in working in brain injury for several decades now, and have seen services improve, but we've an awful long way to go.
Great, and we'll come back to some of those areas that you think require progress, Jackie. If we can come to you now, Toria, and Jane, please.
Hi, yeah, so I'm Toria. I'm one of the founding directors of Steps Rehabilitation. So we're a specialist rehabilitation centre based in Sheffield, but we see clients from all over the UK and outside of the UK. So my background is physio. We've been running for about 6 years. We have 23 beds, and we, as well as working with clients with brain injury, we also work with clients who've had other complex injuries, which may include spinal injury or traumatic amputation. Because we do work across all those different areas, we quite often have very complex clients come to us where they've had a brain injury, but they've also had a spinal injury or brachial plexus injury or other complex orthopedic injuries. So having that diversity allows us to support sort of all those needs that clients may have. We've invested a lot in technology over the recent years, as that seems to be another area that's allowing sort of us to enhance the rehabilitation we do and what we can offer and the intensity that is needed for our clients. And we very much try and have everything under one roof to make that journey for clients as seamless as possible in terms of all the different therapies, the traditional therapies and the other different psychological therapies, including art and music therapy. We have access to sort of several rehab consultants, psychiatry, psychology. So we try and offer everything in one place to address all the clients' needs during the time that they're with us at Steps. I'll introduce Jane.
Yeah. My name's Jane Warbrick. I've predominantly worked in brain injury rehabilitation since 2000. I've qualified in the 1993 as an occupational therapist, very much kept hands-on. A few years ago, came to join the team at Steps. Prior to that, I've worked in both in the NHS and in the private sector, working for a private brain rehabilitation company, Head Injury Rehab. And so I've seen heading the rehabilitation from all sides, really, coming through. And it's really interesting now to be working in this unit to see a different aspect of it and what we can deliver.
Great. Thanks very much, Jane. So we've got a fabulous group of panellists, a wealth of experience and knowledge to allow us to work through some of the key issues around the future of brain injury care. I should say that we were due to be joined by Irwin Mitchell as well, who I think everybody will know. Irwin Mitchell couldn't join us today, but they're very much involved in the future of brain injury. And I'm sure at future debates and events they'll be able to join us and contribute to some of the discussions that will follow on from today's event. If we could maybe start by the panel really isolating what they think some of the key issues are for the future of brain injury care. Maybe I could come to you, Jackie. You know, you finished your introduction by saying that enormous progress has been made, but there's still much to do. Maybe you could say a little bit more about that much still to do bit.
I think Nikki touched on it by saying how lucky the clients are that have case management, have the resources, have the independent sector to provide rehab services. It's those that don't have that joy and go through the process through statutory services and fall off the cliff. And quite often I'm seeing people several years down the road post-injury who've been discharged from hospital, perhaps had some rehabilitation, and are living in the community without the support services that they very much require. So I think for me it's about community rehabilitation and care and support within the community and how we improve access to that.
Great. And Niccola, maybe do you want to add to that? It's quite interesting to hear Jackie talk about statutory services, maybe for some of those services end and what comes after that.
Yeah, sure. Well, I think one of the key things is that particularly people going through the statutory route, but there is just quite a hidden nature about brain injury. So it's not always obvious and identifiable. And actually, some of the clients can't identify it themselves and lack insight into that. So I think often it's not being picked up to begin with, as I said, quite hidden and masked. So there is something around healthcare providers and their ability and their training and ability to really identify what is going on the ground, and that's in all disciplines. All types of rehab and healthcare and social work as well. So that is why people are often not even picked up or discharged. Non-attendance is another big one. Jackie and I were just talking before that people, as I said, they don't identify that they have issues, and so therefore they won't attend, or they just have poor planning and get discharged from services. So there's really this whole batch of people that aren't being picked up in a way, and that's the core of where it all starts.
Yeah, I'm sure we'll come back to that issue. It seems like a key issue of patient access. Toria and Jane, I'd be really interested to hear from the perspective of Steps rehabilitation. What do you see as the key issues? Are they similar to those that other panelists have already mentioned, or are you seeing different issues?
I think a mixture of things. I think, as Niccola was saying, it's really interesting how much brain injury is missed when there's other injuries. And because we do work with clients who've had other very complex injuries, quite often we are the place that's identifying that there has actually also been a brain injury that's just not being picked up. So that's something we've seen quite a lot at Steps. And for those people that are in that position to have been able to come here for rehab, we can then obviously pick up on that and look at what their needs are and address them. We also find kind of the access to rehab for people issue, and people being able to get access to the right rehab at the right time. And I think there's obviously such pressures on the NHS to discharge people as soon as possible, whether that's to an appropriate or inappropriate environment, such as a care home or their home when it's not actually set up for them. So getting access for people can be a challenge, and we do have people that are funded through the NHS as well as people who are funded through their personal injury or clinical negligence claims, and a few other different funding streams as well that people maybe don't always think about. So that the funding through statutory services, through the ICBs, through something called an individual funding request, is that we've learned over the years that they tend to fund more where it's a very serious brain injury, and particularly where there's somebody who's got a tracheostomy, for example. But it is very much a postcode lottery in terms of which ICBs understand brain injury and understand the rehab needs and who will actually invest in brain injury. So it's certainly very, very variable. If you want to add to some of the other challenges, Jane.
Yeah, I think in terms of how people are referred to us, it does feel like certainly some of the NHS funding routes, the CHC routes, it isn't perhaps widely known that there is availability, with the right scenarios to access support here. But I mean, we do predominantly have funded cases, and going back to the points made earlier, that where there is funding, there is rehab, and that's a privilege to be able to provide it. And we're working more and more on our pathway being part of someone's rehabilitation journey. It can be a very intensive part of someone's rehabilitation journey. And perhaps leading on to another topic would be the transition then to home and some of the challenges that are faced there. And I'm sure there's points there that other people are going to bring to the table. If not, we will.
Yeah, I'm sure we'll come back to that. This question of patient support and access seems to me to be crucial. Is there a major issue about making sure that those people that require care and support understand what support's available, and to find new and innovative ways to ensure that those people that require care and support get it and understand which is the right pathway for them? I don't know if you'd like to comment on that, Jackie. Patient access to the services that are available. Is that a burning issue? I think you might be on mute.
I had to be the first person, didn't I?
Yeah, it's usually me.
Yes, I mean, if you've met one brain injury, you've met one brain injury. And every person who's embarking on that journey is going to follow a different pathway, and have different needs, and need to access different types of services. So yes, there does need to be I may be biased, but a case managed approach to enabling people to be directed down the pathways. Part of the difficulty is, as Nikki said, that a lot of the people who work in the community, who work in health, don't understand the nuances of brain injury. We've just said that some of the more challenging cases perhaps find it easier to access those services, but there is a whole cohort of people out there, the walking wounded, as it were, who have equally as high needs that are not being met, and they're ending up in prison services, on the streets, homeless, in mental health, which is not appropriate to their brain injury needs. So there's a big education pathway required here. And of course, those people going out into the wrong services receiving the wrong treatment is a missed opportunity, and from a budgetary issue is going to cost us all and the state far more than if they had access to the right services at the right time.
Yeah, thanks, Jackie. Jenny, it looks as though your tech issues might have been resolved. Are you experiencing some of the same issues with reference to patient access and understanding and the need for an educational programme to direct the right people to the right services? I think Jenny might still be having tech issues. So maybe I could sort of push that towards you, Niccola. I know you work with Jackie in several different levels. Patient access, I think you mentioned as well, and the need for education and the need for clarity about what's available for whom.
Yes, well, exactly as Jackie said. The only thing I suppose to add is just it's that postcode lottery, isn't it? So every service accepts different parts of the population, and every geographical area is very different. And that's why, again, we sort of advocating for a case management approach, if you like. And Jackie and I have both been working with the Institute of Registered Case Managers that is setting up to start a register, hopefully leading on regulation in case management. But in working through that, we've sort of done some work on standards of case management and just breaking it down into the building blocks. So for any person, it is about assessing their needs, identifying what the solutions might be for those, and then signposting to the right services, whether that's private or statutory or charity services in a patch, and being very familiar with those. Education is another core part, but then also being able to review and make sure people aren't just getting lost in the system.
Just coming back to Toria and Jane, could you maybe talk a little bit about how healthy innovation and research is and how effectively it's been funded with reference to brain injury care?
Well, before that point, and just to add to the previous point, I think access to brain injury as well, we need to flag the work of the charities like Headway, because I think the general public often go to those resources first, and they're drawing on their services a lot to help signpost and direct. And I know, I'm sure everybody's very aware of that, so that's just a little bit of a support for the other sectors out there that are supporting the cause and signposting to all the cause for people to access rehabilitation. So in terms of the research and technologies, then something we've invested in here, isn't it?
Yeah, absolutely. We've got quite a range of technology, and over the years we've kind of sort of tried to sort of see what's available, and it's obviously a very rapidly changing world, and it feels now we've kind of got a good foundation of knowledge and experience. Now we're sort of been up and running for 6 years, so we've kind of tried to get a range of technology that will work for clients to support them sort of functionally and from a cognitive perspective. And what we're doing is we're working with a few of the companies that such as MindMaze and Toria, to actually help further develop the products, to make sure that they are being developed collaboratively with a clinical insight, so that it's, you know, with the team that are actually working with the clients and seeing how that would work better or how it could be improved, as well as looking at sort of developing treatment protocols, because a lot of the technology is very new and it's maybe been initially designed for one purpose, but actually there's a lot of other ways it can be used, which is what we're finding. So we're sort of working very much towards that, and we've recently employed a research and development therapist, because there's so much that we feel we could contribute with the sort of unique situation of sort of combination of clients that we work with here, and a lot of the tech that we've got. Some of the equipment we've got isn't available anywhere else in the UK, or is only maybe available in 1 or 2 other places. So we are in quite a unique position, and we want to make sure that we kind of use that to help sort of drive change and innovation around rehabilitation. And kind of one of the things we've just recently have asked our therapists to also start looking at, that again, over time, what we've seen is people come to us at different stages in their rehab, and they come to us straight from hospital when they're just medically stable and at the start of their kind of real rehab journey. But we're finding people are coming to us sort of after kind of many years sometimes, and people are coming to us, and this will probably be another good topic conversation, of being told they have no rehab potential, which is quite a statement that unfortunately is used far too often and often documented in people's notes, and then actually limits their access to getting funding for rehab, whether that's statutory or private services. But we're seeing people come to us later down the line and make massive gains. So we're starting to sort of document where people are coming to us a year post-injury, and build up a database of what progress they go on to make in order to hopefully evidence what we actually are seeing and we know is true, but about the gains that can still be made sort of years after injury.
Well, why do you think that's so common, Toria, that people are being effectively misdiagnosed and told that they don't have rehab potential?
I think there's a few, probably quite a lot of reasons. Some of the things that I think are key in that is, unfortunately, what's I think happened over years is because the services, statutory services, that there's not enough investment in rehab, so therefore there's not an infinite pot of money to carry on providing rehab for people really for the entirety of the time they need it and to allow them to reach their potential. So what's ended up happening is it's easier to say that actually after 2 years or after a year someone will have plateaued and they're not going to make any more gains, because then that allows the services to discharge people, is my belief and what we're seeing. So there are people, I think, who maybe haven't seen the bigger picture, or maybe haven't had the experience to work in a sector where they can see what is possible. So some of the think some of the clinicians that may say that probably do truly believe it, because they haven't seen what's possible when people can go on and have further rehabilitation. So I think it's kind of been a comment that's defined over what is actually available from a service provision perspective. So it's trying to break down those barriers and get people to see beyond that.
Yeah.
And we had a client fairly recently who'd been in the community with not the right setup at all, and really, really struggling, and being told that you had no rehab potential. And this is a client, the young chap in his 40s, and he's done absolutely amazingly well. He's now living back home, but he came to us not mobile, not managing to manage his emotions, regulate his emotions. He had no memory before his accident. He had multiple issues going on, and as well as some other complex trauma injuries. And this is a chap told he had no rehab potential, who by the time he left us was going climbing, was going out to the peaks to fly his drone. He was walking every day. He was able to regulate his behaviours and anger issues and all sorts. I mean, that's just and this is someone that ordinarily, if that hadn't happened, would have probably been, as Jackie was saying, the sort of person who would have probably ended up, being in prison or going down a pathway that, obviously didn't allow him to be supported.
Clearly, there has been enormous progress made with reference to treatment, but Niccola, could you maybe say a little bit about how you see the level of innovation and research across brain injury care? Is it moving quickly enough? Is investment an issue?
Yeah, well, not particularly my area, I suppose, although I also come from an occupational therapy background. So most of us on the call have rehab backgrounds, and anytime that I've been to inpatient rehab units, the technology completely blows me away, actually, which I suppose is a positive thing. It's not like OT used to be anyway. But no, I think in terms of rehab, but I'm not sure that is duplicated in statutory services. So again, that is the same issue that we've been talking about. I'm also not sure that technology necessarily helps with that transition to home and the element of care and consistency in the home. There is some technology that can help prompt and remind and set routines, but actually that doesn't always replace that that guided support, that human element side as well. So Not sure I can add any more on that.
And with reference to sort of case management, Niccola, is your experience as well that there is a lot of misdiagnosis and there is a degree of underestimation when it comes to the potential for people to go through successful rehabilitation?
Yeah, I mean, we don't see that as much when we pick people up very early after their injuries or accidents. It is people that have come along years later, as Jackie alluded as well, or we both actually do some expert witness work. So sometimes you're just seeing people that haven't had access to that same pot of funding along the way, where things are being missed. But usually a good case manager on board, and they'll get the right assessments done as soon as they can possibly get them done. So I think that was, sorry, I think that's the answer to the question.
Great. No, that's really helpful, Niccola. Jenny, are you back with us again?
Yes, apologies, some IT issues, but yes, I just really want to pick up on some of the discussions we've had already, and to add to that, there's been some really interesting points raised. And from a QEF perspective, what I was trying to explain earlier was that we are quite unique in that we do have 4 different client pathways, and within each pathway we do have some set contracts, for example, which are NHS partners, and within those contracts our practice can be somewhat guided by length of stay and how long the client can stay with us. But really what we are looking and striving towards delivering and offering is that client-focused and client-centered rehabilitation that's really set around the client's goals, which are meaningful to them. And what we want is those bespoke packages, and have that model of a rehab, which we've spoken about, where patients can come to us in an inpatient facility where they'll get the level of input based on their clinical assessment and need. We're trying to look at different ways in which we can up our level of intensity, but then that transition community and how we can work more closely with partners to make sure that transition home is smooth. But then in addition to that, we want to really focus on the aspect of families and carer training, looking at when it might be inappropriate to reassess that client once they've gone into the community, how to support them so that those gaps that currently do present don't leave the client sort of left out in the community and wondering what's next. And is it that we can bring them back in at a certain stage post-discharge for a review, a reassessment, and then whatever what the client's needs are, and we offer as inpatients, we offer outpatients, we also offer the respite care as well, which can be the added bonus for clients and their families and carers. But for us, what we're really trying to look at is offering that bespoke package that's individualized to the client and what their needs are. So it's really trying to offer the mix, but put the client at the center. And I think that's what's really important in trying to offer effective quality rehab.
Oh, that's really helpful, Jenny. Could you maybe say something about the quality and quantity of investment in some of the services that you provide and the others provide? I'm quite interested in the point that Toria made about the degree to which financial expediency might limit some of the services that are offered, both with reference to public sector investment and private sector investment. Any thoughts on to what degree investment could play a bigger part in accelerating some of the pathways, some of the treatments and some of the outcomes that are offered?
I mean, yeah, absolutely. To echo what some people have already said. I mean, obviously, the more resource one has access to, the more you can buffer and up the quality. Currently, you know, we follow our standards, the BSRM, to ensure we deliver what sort of the recommended national guidelines offer. But in terms of service delivery, we're currently working to put in place an integrated care pathway for all of our clients that come in under the neurological pathway, to ensure that all of our practices are evidence-based, and to ensure that we deliver the level of quality that we want to based on the clinical guidelines. But in terms of adjuncts to therapy, which really I feel is really key, because no two clients are the same. So we want to be able to offer a range of approaches to rehab that's fitting for the client. So things like access to technology, such as the tire motion kits. We've recently been successful in a funding bid where we went out and put a proposal in place, and as a charity, that's another stream of funding for us, is to try to put proposals and go to other funds and organisations that may be able to sponsor and fund us, because we don't have that sort of flow of the statutory funds that some of the other organisations would have. And again, we're looking to do the same, for example, with Chroma. We've put a proposal in place to see if we can get funding to allow us to embed music therapy into our day-to-day practice. So there's lots. This is a really exciting time for QES, but the work that is required to secure the funds to allow us to deliver quality and effective rehab, it's quite intense, and it's not as quick and free-flowing as one would want, and I'm sure that's probably similar to the other people in the group here today.
Thanks, Jenny. Jane, I sensed that you were twitching there when I...
I'm sorry. Well, I was thinking about the technology a little bit more, in terms of how the types, to develop the theme about the types of them, and I think I'm preaching to the converted here that, of course, assistive technology has a big role to play, and certainly environmental technology going into somebody's home. And we do also have to look at NHS provision as well, so working with teams who provide it through the statutory sector for people at home. There's access to the specialist people who can assess associations for high-level tech. But the sort of tech that we're using here in terms of the Mind Motion Go and some of the other platforms, I think work is going to be zooming forwards now to allow patient access to some of these technologies at home. We're hearing more about people logging on and having their user account to conduct hand therapy at home and to conduct balance exercises at home and that type of thing. So that's all well and good, but as we all know, levels of motivation, ensuring that rehabilitation is done qualitatively, and that there is some vicarious link to qualified therapists to follow up and ensure that's done correctly, is something we need to be aware of going forwards. There are possibly things that we need to ensure are followed through if that type of intervention is proving to be useful. I mean, there's too many to name, but I've got examples if anyone's interested.
Yes,
okay.
I would. Yeah. But I think some of the advancing technologies, right now, I mean, I'm a neurophysiotherapist by background, and technology really is quite hot right now, and there is a lot of discussion. And the pieces of kit that are being, worked on alongside clinicians, I feel, are those that are going to be most reliable and robust in taking our rehabilitation journey forward in the right direction. It's, the quality rehab. So, for example, the tire motion, the Pablo kit, it is one that, whilst it has it's a sensor-based sort of rehab device that can be, used both for unilateral or bilateral upper limb training, it does have those different games and interactive technologies for the client, but it can be linked to tasks that are specific to their daily routine. And again, it is set in a way where you can conduct objective assessments, you monitor, there's a reporting system. And so those pieces of kit I feel are more reliable and sustainable in the long term, because you can really monitor the effectiveness of them. And I think that is something that's really important when we want to determine what technologies we want to use.
Thanks, Jenny. Can I just ask if there are any subjects that we haven't covered that people would like to air and talk about? Niccola.
I think we should say something about care, as in support in the home environment, either from Jackie or I. So lots of talk about rehab and how that's progressing and how that's available to so few people. So, huge issues there. But, the burden, I suppose, on caregivers and the lack of access to care and support is also critical for people, because people go home from hospitals and inpatient rehab services. So that is just an area that is, been on the news a lot, is desperately in need of funding, is social care, but also the restrictions, really, the limitations on what can be provided through statutory services. So I think that is a great big need. It's also carers and support workers that are actually able to work with people with brain injuries, because they can be very challenging and demanding, and it's sort of really burnout work in a way. So that is another whole area. I don't know if Jackie wants to add a bit to that side, but certainly needs support in order to be able to sustain where people get to in terms of their goals, and stop them from re-offending or offending and all those sorts of things, really.
Jackie?
Anything else, Jackie? Sorry.
Yeah, I think I'm sitting here listening to the rehab research and innovation that's going on at QEF and at STEPS, and it's fantastic, and all credit to the hard work that everybody does there. But at some point, as Nikki says, people come home, and the research in community and long-term rehabilitation is still limited. So it's that qualitative research which is imperative. It's encouraging that there are projects like the Heads Together project and funding from the NIHR that is going into that, and there's a group of excellent researchers working on that. So it's growing, but there's an awful long way to go. We are in the middle of a care crisis and struggling to get skilled and supported carers. It's I always say to the case managers that I work with that we are only as good as the support staff and the rehab staff who are working with our clients. It doesn't matter what I know. It's what they're doing with them day to day, 7 days a week, that really makes the difference. We can guide and support, but without that network of social care and rehab care around people, and we need to recognise the skill of the staff that we work with, and there needs to be a structure within social care to enable that to happen. When I started the talk, I said that there was a long way to go and that people were falling off the cliff into the community, and I think that's still the case, that people are being rehabilitated to go home, but not necessarily to live at home and in the community. And that a lot of our clients who lack insight, who are dysexecutive, who have difficulty planning their lives, are living impoverished lives, and that's where things need to be addressed. It's that social care.
Yeah, no, you're right, Jackie, and it's a big challenge, and we try as best as possible to prepare the clients for the next stage of their rehab journey, and we do work with them within the community. We try and link them to the right kind of support charities. We also have a sort of training school within STEPS, and we provide training for the care support workers that are going to be working with our clients. So we kind of support our clients within that recruitment process of trying to find the right team for them. Obviously, finding a team and having enough people is very difficult at the moment, which is causing delays with discharges. But when we do get the right team, they're very much involved in that process, and then we work with that team to train them so that they get to know the client and get to know them, and try and have, wherever possible, try and have very much a phased transitional process of that discharge for somebody to adjust, because it's a huge step, and they may have been in hospital for many months before they even come to us, and it can be a long time from their injury to when they then return home, and it might be a home they've not even known because it's a new home, and all the things that you will know, because as a case manager you'll be very fundamental to coordinating for them, but that transition is really challenging, and we sort of do as well as we can. I think we can still do more, but there's a lot of work, as you say, to try and maintain for people. And I guess on the flip side of that, for the people that are living in the community where they've not had the right rehab, or they've ended up in a care home, or they've been missed, or there's not been funding, there is, I don't know how you tackle this one, but there's probably a lot of people like the client I mentioned earlier who actually wouldn't be the same kind of burden in terms of the needs for care going forwards. They might not need care, or they might only need one carer, or they might need to be able to live fairly well functioning with a minimal support. But a lot of those people are actually not getting to the point of being able to realise their potential. So that's, if you can tackle that, you'll actually reduce, the issue. But it's not a simple one to resolve.
And similarly, what you were saying, that's I guess that's sort of a place where QEF are at, in that we are really work closely with staff teams in the community, hand over patient sessions, whether it be the or the therapist. I mentioned earlier, we really are looking at that model so that when clients discharge, it's not a discharge goodbye and we won't see you. We want to have those check-ins, the pathway post-discharge, how we can work with our community partners and follow up, sort of triage assessments, bring them back for review, make our recommendations as to what might be needed. We're also currently in the process of, and we're hopefully going to get some funds secured, we deliver some outreach projects as well, because we understand many clients in the community that really struggle to access services, or don't have the competences or the ability to go to gyms or leisure centres. So what we're putting in place is a NeuroFits type strength conditioning group as a community outreach project for some clients living with brain injury, so that they can come to us and be a full 12-week programme with assessment and outcome measures at the beginning and at the end, to really make that client maintain their level of physical skill, if you like, to make them robust and strong and continue living in the community, because we realise that once one goes home, some of the challenges really do become insurmountable. Really at QEF, we're really looking at ways in which we can support them more. One of our pathways is also the longer term neurological care as well. And so for clients that we really do feel are struggling at option where they and stay with us under the longer term pathway, and that is also something that we're really grow upon the current need. So that's another quite exciting sort of venture that we're building on at the moment, and we want to work with our partners with it in doing that. And then I guess the other thing for us really, that as a rehab service as a whole, it is like so that we support the carers in terms of the number quality measures at a charge, which might help support the ongoing needs of the client. Also in terms of review, post-patient stays, things like the RCM tool, looking at other dependency tools, because that might also support what level of intensive care that may need, and just get more complex once they leave home. So there's lots of things we're doing at the minute, and some things we really need to think about.
Thanks, Jenny. You were coming in and out there, but I think we got the general gist of what you were saying. I didn't want to interrupt you because I think we could piece together the points you were making, and that it was important that we got the chance to hear that. We could, I think, talk for hours about some of the themes that we touched on today, in a sense that there are separate, very worthwhile, intensive discussions to have about some of the subjects that we've covered. But of course, we don't have hours to talk about those things today, possibly in the future. So I'd like to sort of draw things to a close and ask each of our panellists for just a few words, final thoughts on, for our panellists, what the key priorities and areas of focus should be and need to be to move forward the future of brain injury care. If I could maybe come to you firstly, Niccola, just for some words and final thoughts, please.
Thanks. Yeah, just to be boring again, it is. Well, it's about funding, isn't it? Really, both for that rehab phase and the social care phase. I would say something about having a guided approach through a case management model are really the crux of it for me. And I was just listening before. Some of the solutions aren't necessarily costly. You know, sometimes it is just about overcoming some more straightforward barriers about accessing services. So it's, you know, transport to get to and from, those sorts of things. So it's not necessarily that it's huge amounts of funding. It's being able to identify people and have a good service to follow them through in a way, so they don't fall off the net.
Far from boring, Niccola, I think that's absolutely the heart of the things that we've been talking about. Jenny, final thoughts?
I mean, I think it's touched on the importance of funding. We've got lots of ideas and thoughts on how to deliver that evidence-based rehab throughout the way home and beyond. But it is thinking through the practicality and the funding. So it's almost the pulling together of all the ideas, how we integrate from everything, thinking about how we can make that come to fruition.
Great, thanks, Jenny. Toria and Jane?
Yeah, we'll try and tag team this. I think case management side of it, getting the right kind of case manager involved early on makes a massive difference to that person's rehab journey that we see. And we often get clients calling us very early on when they're still in hospital or their family member, and they're not even at the point of instructing anyone yet. So it's something we very much always often end up giving them some initial guidance on that and why that's so important. And then I think having really high quality, truly holistic access to, you know, to the right rehabilitation at the right time, and having a situation where that isn't a postcode lottery, it isn't just about, you know, whether somebody's got a claim or not got a claim, having that access to rehabilitation for everybody, kind of talked about transition into community. And I think there's a lot of need for, you know, the wider research that Jackie talked about, but also education as well, I think is really key, not only for like kind of families and the clients, but for clinicians who are maybe working in the acute sector, so they actually have more of an understanding about what's possible and what happens to people even further down the line. We talked about sort of, say, our rehab centres to community, but actually the hospital gap between what we do and the community is even wider. And I think sometimes in hospital, these are people they think aren't even going to survive and are going to have no quality of life, and they never really truly get to see what somebody can achieve, and it can be very far from what they perhaps ever anticipated at the start of their journey.
And I think as well, the way the acute services are working, they're not afforded often the luxury of time to even consider what's going to happen beyond their crucial interventions, and the crucial intervention, the major trauma units, absolutely doing an amazing job. And getting behind the time for change really document or everything it highlights is something already there really that is going to lead to support the services developing.
Thanks, thanks, Jane. And Jackie, you get the final word.
Well, I think everybody's said it already, really, and I would wholeheartedly agree that the Time for Change document highlights the need for this seamless transition between services, the true need for integration. And it won't surprise you to know that I think that a case management model to accompany people through that journey is critical. I think funding, it always comes down to funding, and we need funding to research the evidence base to give those strength to those recommendations. And because rehab is only rehab if it is effective to the people that we work with and is meaningful to those people and leads them to a quality of life. But I would just echo everything that everybody else has said.
Thank you, Jackie. And that concludes this NR Times roundtable. I'd like to say a very sincere thank you to all of our panellists for sharing their knowledge, experience and insight with us. If any of the subjects that we've covered are of particular interest, I'd urge people watching to get in touch with our panellists or their organisations and follow up. I'd like to thank True Rehab for being the headline sponsor of this NR Times roundtable. And again, Irwin Mitchell, who would have been with us, thank you for their support. If you're watching this, thank you for giving up your time to watch. For those that are watching this on YouTube, I'd encourage you to go to the NR Times site and look at some of our other roundtables. For all of our panellists, the content and this roundtable will be up on YouTube within 24 hours or so. And it only remains for me to thank all of our panellists once again for contributing. It's been a great discussion. Thank you.
Thank you.
Thank you.
Thanks.